Hey guys, happy new year guys. After a long time I think I'll be coming back putting a videos. Today our topic of discussion is mitral stenosis. First we will be seeing the pathophysiology and what are the clinical symptoms the patient can experience during the course of the disease and other signs. Okay, so what is mitral stenosis? Nothing but your mitral valve area is narrowed due to some pathology. So what are the most common causes for this mitral stenosis? Is most common your rheumatic heart disease is the first most common, followed by your drug therapy like methotrexate drug therapy, or patient will be having some mucopolysaccharidosis, associated mucopolysaccharidosis, SLE, systemic lupus erythematosus, rheumatoid arthrosis. These are some of the causes which can present with the mitral stenosis. So per se, what is normal mitral valve area? First we have to know normal mitral valve area. So normal mitral valve area is approximately around 4 to 6 centimeters square. So when it is narrowed due to some disease process, due to rheumatic heart disease or something, there will be, the mitral valve apparatus consisting of anterior leaflet, posterior leaflet, commissures will be there, and there will be cardiac tendineae which attach to the papillary muscles. Okay, so there will be occurring commissural fusion, thickening, fibrosis of this leaflets will occur, which may resulting in narrowing of the mitral valve area. So normally this duration how much it will take is from infection to disability. It will cause disability of the person to limit the activity will take approximately around 10 years. From mild mitral stenosis asymptomatic to become severely disabled, that means more severe symptomatic, it takes duration of about 10 years, normal duration. So the patient is actually can present with a progressive symptomatic lesions. The patient can present either as a progressive dyspnea, which may progress that from NOH, and which will be stratified by NOH, and there is New York Heart Association grading from 1 to 3, 1 to 4, or 1 to 3, depending upon the grading severity of dyspnea. We can classify according to them. Okay, so the mitral valve area is narrow. Because of this narrowing, what will happen? Normally there is a gradient exists between left atrium and left ventricle. Because of the gradient, blood will flow from left atrium to left ventricle. At the phase of diastasis, that is at the diastole, at the phase of diastasis, this gradient will disappear and next systole will start. So in mitral stenosis, what will happen is because of the stenosed mitral valve, because of this mitral stenosis, the blood flow from the left atrium to the left ventricle is started to decrease. So the gradient between LA, LV is started to increase. So the pressure in the left atrium is started to increase, which will be transmitted back to your pulmonary venous system. Okay, and this as the stenosis is going to worsen, then what will happen is there will be restriction of the flow across the your mitral valve. So LV preload is started to decrease. As the preload decrease, what will happen? Your cardiac output will started to decrease. When cardiac output started to decrease, what will happen to there will be reflex vasoconstriction of the systemic vessels to increase the BP. So there will be reflex vasoconstriction, which will further deteriorate the cardiac output. So the patient, as the stage progresses, the patient will become severe easy fatigability and more dyspneic because of this decreased cardiac output. And another thing what is happening is there will be increase in the left atrial pressure. Normal left atrial pressure is 5 millimeter of mercury. As the disease progresses, that is mitral valve area less than 1 centimeter of 1 centimeter then square, then what happens is the flow across the mitral valve is restricted. So left atrial pressure started to build up and increase to about 25 millimeter of mercury. So when the pressure rises to about 25 millimeter mercury, there will be passive transmission of the pressure to the pulmonary venous system, which may resulting in reflux pulmonary hypertension. It will be relieved when your mitral stenosis is got relieved either by surgery or not something. When it is continued to withstand, then it causes for more number of years, then it causes the arteriolar vasculature muscle hypertrophy, which may resulting in pulmonary vascular hypertension. Pulmonary hypertension may result as the end stage. Okay, so when pulmonary hypertension results, what will happen? to your right ventricular outflow. So the ventricle have to pump the blood against this resistance. So when it started to pump against the resistance, this ventricle have going to for hypertrophy, and initially to go for hypertrophy. When it is not compensated, it go for right ventricular failure. So what are the symptoms is because of the in mitral stenosis is, first I told there will be decrease in the cardiac output. Second, I told there will be transmission of this LA pressure, there will be enlarged left atrium. So symptoms related to the left atrial enlargement due to stenosis. And third, I told there may be transmission of pressure to the pulmonary venous system, which may resulting in increase in the pulmonary hypertension. So pulmonary hypertension related features, and which may finally resulting in RV failure. So individually we will be seeing the symptoms. So first, there will be decrease in cardiac output. So the patient what can present with the decrease in cardiac output, there may be most commonly easy fatigability, breathlessness on exertion, or breathlessness depending upon the involvement of this valve. Next, another thing is the patient can present with syncope because of this low cardiac output. The decreased blood flow to the CNS resulting in transient TA, either transient ischemic attacks or syncope can occur because of this. And there will be left atrial enlargement because of this increased pressure I told. So increased left atrial enlargement, what will happen? It cause your recurrent laryngeal nerve, which is encircling around the aorta. So left recurrent laryngeal nerve compression, this may resulting in hoarseness of voice, which is called Ortner syndrome. And another left atrial enlargement, another finding is atrial fibrillation. So actually what happened is, initially the gradient is started to increase, and as it becomes severe, the left ventricular preload is entirely dependent on the atrial contraction or atrial kick to maintain the forward flow, to maintain the cardiac output. So atrial kick will become a more dependent factor in severe mitral stenosis. So atrial fibrillation can occur, or patient will be having some thromboembolic features because of this enlarged atrium that is more prone to stasis of the blood. Over there, maybe thromboembolism associated symptoms can present with the patients. And another thing is your pulmonary hypertension will be there. You can identify the we can identify the signs, symptoms. Breathlessness will be there, and associated signs will be that AS2 will be loud, and A2P2 component, depending upon the pulmonary hypertension, if it is there, then there will be reversal of the A2P2 component will be there. And RV failure findings. So RV failure features will be, what are the things? 4 main things. Raised JVP will be there, pedal edema, then hepatomegaly will be there. So at the end stage, initially to failure, at the end the patient also have, if the LV output is also reduced, then the patient will be go for the end LV failure features also will be there, like orthopnea, paroxysmal nocturnal dyspnea. It is in critical MS, orthopnea, PND, paroxysmal nocturnal dyspnea. So these are the symptoms the patient can present with that. So in history, when you are taking, you have to ask for ECA fatigability, breathlessness, syncope symptom, hoarseness of the voice is there or not, and associated pedal edema, that is ankle edema, is there, or orthopnea, paroxysmal nocturnal dyspnea. Breathlessness, you have to mention NYHA grade, which grade the patient is there, NYHA grade 1 to 4. You have to categorize the patient grade and then mention. Okay, so these are the main, and another is hemoptysis symptoms. Hemoptysis can also occur. I told no, because of this increased LA enlargement, there will be transmission of pressure to the pulmonary venous system, so which causes increase in pressure over the pulmonary venous system, causing rupture of the bronchial veins, which may resulting in hemoptysis at the late findings. So these are the main symptoms related to your mitral stenosis. Okay, so now we have to grade the mitral stenosis. We will be seeing little bit of grading. After that, this video will get completed. Okay, grading will be mild, moderate, and severe MS. So depending upon the mitral valve area, we can classify. Mitral valve area severe means less than 1 centimeter square. So 1 to 1.5 centimeter square is moderate, and severe mild means more than 1.5 centimeter square mitral valve area. So depending upon the pulmonary artery pressures also we can classify it mild moderate. There is less than 30 millimeter of mercury is mild, 30 to 50 millimeter of mercury is moderate, and more than 50 millimeter of mercury is severe. Okay, and depending upon the symptom you can also classify both patients with NYHA grade 1 and 2 is coming under mild stenosis. Grade 3 NYHA grade 3 is coming under moderate mitral stenosis, and NYHA grade 4 is coming under severe mitral stenosis. So these are the patient's symptomatic, and these are the pathophysiological findings, and you can grade the mitral stenosis according to the degree of narrowing of the mitral valve area. Okay guys, let's see the what are the examination finding, what are the auscultatory findings, and how will you investigate the patient, and how will you manage anesthetic management in the next video guys. Thank you guys.